Hello, and welcome back to the Intent Medical Group podcast. I'm Dr. Sammy Khalili, and I'll be your guide as we explore the stories, breakthroughs, and people behind exceptional care across our team and others. If you're new here, we're so glad that you're joining us. And if you're one of our returning listeners, welcome back. Today, I'm excited to welcome back a very familiar voice, Dr. Neil Mundi, our Chief of Head and Neck and Craniofacial Neuro Oncoplastic Surgery. It's a mouthful. Dr. Neil Mundi is a trailblazer in our field, and it's always an honor to have him share his expertise and insight with us. Let's get into it. Hey, buddy, welcome.
Thank you very much.
Yeah, it's good to have you here, and welcome to our new space.
It's beautiful. Job well done.
Well, I'd love to say that I had everything to do with it, but we have to give it up to our producer, Yasmina, who's been amazing with all this.
Shout out to Yasmina, who's off camera.
Yeah.
Thank you very much.
Thank you very much, Yasmina, for finding this wonderful space for us. That's a bit better than my office, I guess, where we were doing this for the last several episodes.
Yeah.
So, a lot of our listeners already know you. But I'll just kind of rehash quickly. Neil's our chief of oncoplastics and microvascular reconstruction and head and neck cancer for our team, and is charged with essentially handling a lot of our big head and neck cancers that come in here, and then fixing a lot of the defects that people get when any kind of problem comes in from the neck up, essentially. And even sometimes you're helping a lot of the spine team. We'll help them with some of their problems to reconstruct their defects too.
Yeah.
So, I thought we'd bring you back here, not to talk as much about that, but about another big element of your practice, which is pertaining to a lot of the endocrine surgery that you do. Mm-hmm. And specifically, we were going to focus in a bit on thyroids, because you and I both know that's something that constantly comes in all the time in the clinic. And people really worry about their thyroids. I mean, this is the funny thing. You tell me how you feel, but my sense for me as a ear, nose, and throat surgeon like yourself, we don't worry as much about the thyroid cancers as much as the people do. Quite a bit.
Absolutely.
Why do you think that is? I'm just curious. So
I think there's a lot of anxiety that comes around having a nodule or a mass or a growth in your thyroid. Mm-hmm. So as soon as a patient may have an ultrasound of their neck for a different reason, they may have a CT scan of their neck for whatever reason, and these thyroid nodules pop up, and then as soon as they hear the word nodule, a lot of people equate that to a cancer. Mm-hmm. Or if they feel something in their neck, automatically your mind jumps to what's the worst case scenario, which would be having a cancer there. But with respect to thyroid nodules, they're extremely common, right? So about 50% of people by the age of 60 will have a thyroid nodule. Now, you may never know you had one because most of the time they're benign, 90%. I'm
just going to emphasize that. That's 50%. That's a lot of people.
Yeah.
And then that's not just women. That's all people.
General population.
Okay.
The incidence or the frequency of it occurring is higher in women. The incidence also increases as you get older, so it becomes more and more common. But overwhelming majority are benign, so 90% are benign, and generally they don't cause you any symptoms. Now, if they get really large or if they do develop cancer, then you can have particular symptoms that you want to get evaluated for, but generally it's not the case.
So a lot of people, when they're worried about their thyroid or things like that, I guess the big question a lot of people when they come and ask us, how would they never know? Or is this mostly that people just incidentally find the problem?
I would say in my practice, and I think you share this experience, as do most ENT surgeons, it's incidental. They were getting worked up for something else, or they were getting a one-year checkup at their primary. Their primary felt their neck, felt maybe a bit of fullness in the lower neck, or maybe something that wasn't considered to be completely normal. Then they get an ultrasound. Then it shows up as a thyroid nodule. So I would say, if I had to put a percentage on it, about 80% of patients that I see tell me that this just happened all of a sudden, incidentally. They didn't have any symptoms. Somebody told them they had a thyroid nodule.
Right. I guess the big thing for me, I try to tell the patients, and you tell me if that's how you manage them as well, is that it's when they find the nodules not to panic. Because like you said, they are so common and incredibly common.
Yeah.
And so, we do get a lot of people who get very, very worried and fixated that their problems are sort of like being focused in on because of their their nodule, and it may not be, but
Yeah.
it's important to get it investigated, as you would say. So kind of take us through the journey of that. Like what happens next? Person X finds out that they have a nodule.
Yep.
What do we do?
So there's two ways of investigating it. So one is through lab work or blood testing. So particularly thyroid hormone testing. So we want to know, is your thyroid hormone level normal? Is it high or is it low? That's the first step. The next step is to get ultrasounds of your thyroid gland. So the ultrasound, is actually the best way that we can look at a thyroid gland, way superior to a CT scan or an MRI, because we can actually characterize the nodule. They can look at the nodule and tell us, okay, where is it located? How big is it? And then there's a list of features that we look for within the nodule, which can give us an understanding of how concerned we should be of whether or not there's a cancer in there. So certain features like calcium deposits, irregular borders, the shape, the width, all of those come into play to give us a composite score, which can tell us how concerning the nodule is. So I would say start with a lab test, figure out if the thyroid is functioning normally, and then get an ultrasound as your next step.
Now, if someone, let's say, had a thyroid blood test and they had a nodule and let's say it was elevated, are they supposed to get more worried or less worried, or not at all? Just it's part of the investigation process.
So that kind of tips you off that it may be what's called a hot nodule. So a hot nodule is a thyroid nodule that's producing too much thyroid hormone. And when that happens, symptoms that people can get are things like heart palpitations, feeling hot all the time, hair loss, skin changes, those kind of, because the thyroid affects everything in your body. It really affects your metabolic rate, a lot of different organs. So in that case, you can have some of those symptoms manifest. Not always, but sometimes you can. And then that kind of should point you towards getting some additional testing, which are usually ordered by endocrinologists, who are kind of the experts of the hormones in the body. In particular, they can do what's called a radioactive iodine scan. And they can basically look to see whether that nodule is actually producing too much hormone. If it is, then there's different treatment options that patients have. You can get started on medications to kind of cool off the thyroid gland. You can get radioactive iodine to try to do that. Or in cases where that doesn't work, you could get surgery. But typically that workup is kind of directed by the endocrinologists, and they kind of take ownership of that and then kind of direct which testing patients would need.
Okay. And let's say now is the opposite. I find out that the hormone level is way too low. What would that tell us?
So, in a case where you have a thyroid nodule and you're hypothyroid, meaning you have low thyroid hormone levels, that makes you a little bit more concerned that there could be some atypical cells or some malignant cells within the thyroid nodule. Again, it's not a guarantee. Hypothyroidism is very common. In the vast, overwhelming majority of cases, it's not just because you're hypothyroid doesn't mean that you have a thyroid cancer, but it tips us off a little bit that more investigation should be done. Those investigations really depend on what the ultrasound showed. If it shows that the nodule has a lot of high-risk features, then we may order a biopsy of it.
So what kinds of high-risk features should, if they're getting a report, let's say a patient's grabbing it and they're saying, oh my, I see all these things, what do they mean? What kinds of stuff would tip them to say, I need to have this investigated more quickly, rather than just saying, I can relax a little bit here?
Yeah, so the first characteristic is, the size of it. If it's a really big nodule, say greater than 4 centimeters, that's something that should be investigated pretty quickly. If the nodule itself is more solid, meaning it doesn't have a lot of cystic quality or fluid within it, but it's more solid, that's a feature that's a little bit more high risk. If it has calcifications or calcium deposits within it, that's something that we want to pay attention to. The shape of it, if it's taller than wide, that's a little bit more of a high risk feature. And also if it has irregular borders. So if it's not a smooth, round nodule and they note the borders are a little bit hazy, a little bit irregular, is there any concern that the nodule is spreading outside of the thyroid gland? Those are all things that we want to be concerned about, and we want to act relatively quickly. Okay.
So now let's say you found that the person is low thyroid, have some features, not all of them that are suggestive that there might be something going on. What do they do next?
So the next step is, if you come to see an ENT surgeon, that's generally the next step once you get a nodule that somebody thinks you may need a biopsy for. Then we can do a biopsy, which is generally done with what's called a fine needle aspiration. So either the practitioner themselves or a radiologist can do the procedure. And it's generally done under ultrasound guidance, meaning an ultrasound probe is used to locate the nodule. Then a small needle is used to withdraw some cells from that nodule. Those cells then get sent off to a pathologist who takes a look at them and gives us a read. So they give us an understanding. And there's actually, in terms of the biopsy results, there's kind of a grading system, which is called the Bethesda criteria or Bethesda system. And it kind of, they give you a score based on what they see in the cells, and that can give you an understanding of whether or not it's something that's totally benign versus cancerous versus some shade of gray in between.
Yeah. The Bethesda system is a very good system, and all it really does, as you would say, it just manages risk in terms of the profile for whether someone is high risk or low risk for having a potential tumor that's there. Yeah. And I guess the question, I guess for you now, has anything... This is one of those disciplines, and I've seen it. I wonder if you've seen it as well for as long as you've been in practice, that it's constantly updating and constantly changing as it moves along. Have you noticed any subtle changes in the last 5 to 10 years where, now what used to be something we would worry about more, we don't as much anymore?
Yeah, there's really been a paradigm shift in how we treat even thyroid cancers, depending on their size. So, when we were training, uniformly almost, a thyroid cancer, didn't matter how big the nodule was, meant you're getting your entire gland removed. And, when you get your entire thyroid gland removed, the big thing that happens is you lose that thyroid hormone production. There's nothing that's going to produce that hormone like your thyroid, so you need to be on medication to supplement for the rest of your life. In addition, the more extensive thyroid surgery you have, there's some increased associated risks that go along with it. So risks to, the glands that produce the hormone that controls your blood calcium levels, the risks to the nerve that controls your vocal cord. Those are in the neighborhood of the thyroid gland. So those are just put at a little bit higher of a risk when you take out the whole gland versus not taking out the whole gland. So, generally now what the recommendation is that if the nodule is less than 4 centimeters, you're okay to just take out 1/2 of the thyroid gland, not the entire gland, to try to prevent you from requiring lifelong hormone supplementation and to mitigate your risks surgically as well.
That's a big change, because you're right. Because for many years, for up to the last, close to 15, when I first started training, it was all basically you would remove the whole thing and that'd be done. Yeah. But you're right. It's a nice thing to be able to do, particularly for a lot of these low grade type tumors that they could probably do very well without the entire resection of the gland itself. And people really don't, as most of the public, they don't like taking pills. So if they can avoid it, that'd be great. Yeah, absolutely. And another thing that's actually changed as well, Sammy, is that in terms of the pathology results in the biopsies, we're using a lot more molecular testing now. So, as I mentioned, you have this Bethesda system, which goes from totally benign to 100% or almost 100% of cancer. All these shades of gray in between, molecular testing is a special test that can be done now where we can actually analyze the DNA profile of these cells, look at the mutations that they have in them, and then correlate those to a risk of malignancy. So it just makes things a bit more granular for patients, gives them a little bit more information to work with. And sometimes that can be the tiebreaker between, do we just observe this with ultrasounds in maybe 6 months to a year versus do we proceed with surgery? Which is great. This is another step closer to, in general, what we're seeing in medicine now, particularly when it comes to cancers and malignancies, is becoming much more personalized in the approach. Yeah. And this is one of those steps. Yeah. I think it started with, the company was Afirma who did that way back when. And now I'm sure there's more than them who are doing them now, but which is great, which is really good news. Yeah. Any differences in terms of if someone comes in with hypothyroidism or just their euthyroid? Now for the public, euthyroid just means basically that they're normal thyroid levels, even though you have a nodule, so which can happen. Anything that you notice the difference with the risk profile if they're hypothyroid versus just euthyroid, the whole overall, or no, not really? Not in particular. It's actually the opposite is a little bit more concerning. So if they're really hyperthyroid and you take them for surgery, you just have to try to normalize their hormone levels before surgery. So there's some associated risks with anesthesia and performing surgery when somebody's uncontrolled hyperthyroid. So with the normal thyroid function and the hypothyroid, I haven't noticed too much of a difference in their risk profile. Well, that's good to know. Yeah. So thyroid cancers, there are several. Are there any new ones since I last graduated? There used to be only 5 with a couple extra variants. I'm sure it's been bifurcated now a bit more. Yeah. So I think the biggest difference from maybe 10 years ago or so, there are some entities that are
kind of these non-invasive cancers. Invasive meaning it doesn't, the cells don't disrupt blood vessels, go into lymph nodes, break outside of the thyroid gland. So there are some of those variants, which kind of are cancers, but now are kind of being considered not cancer because they're not invasive. So there's a little bit of nuance there. In addition, you mentioned some of the variants. I mean, I think the list of variants of papillary thyroid cancer, which is the most common type of thyroid cancer, has been expanding. There's these very, specific types, which can be a little bit higher risk for invasion of structures, spread to lymph nodes. So when we see pathology reports that say, okay, this is a papillary thyroid cancer with some, let's say, tall cell features, hobnail features. These are just names of different types of cells.
Hobnail.
Hobnail. So, these just make us think a little bit.
Pathologists get very creative with how they describe certain things.
They always do. They always do, absolutely. But that just makes us think a little bit harder about, okay, do we need to be a little bit more aggressive with our surgery to treat these patients just because they're a little bit more aggressive?
Okay, that's awesome. So now we've gotten to a point of you select, a person in terms of, well, are they going to watch this nodule for a certain period of time? We're going to do something more or take another test of it. Because that's not another possibility that you're just not happy with the results that are coming through. We just do another sample, the fine needle aspiration biopsy. All that means for anyone else just who doesn't know is just that we're taking a needle, putting it in it, and just drawing out some cells. And there's a specific kind of pathologist that it goes to. It goes not just to the general pathologist. It goes to someone who's specializes in something called cytology, which is a person who's like all they do is look at groups of cells together on a slide, not in the same way that a pathologist does where they're taking a piece of tissue, but they're just clumped. If you ever had the chance to kind of go do this, it's quite amazing that they actually can see what they see when they're looking at these things, because it doesn't look like much initially, but they're very skilled at doing this.
Absolutely.
So then now you get to the point where you want to take the thyroid out. So, I want you to tell me, as if I don't have a clue what's going on, what happens next? Walk me through it. I'm your guy. I'm about to get thyroid surgery. What are you going to talk to me about?
So, the first thing that you always want to talk to your patients about is what are the risks, right? So what are the risks of surgery? So there's general risks of surgery, and then there's risks of thyroid surgery in particular, which I've kind of touched on, but I'll expand on them. So in general, every time you go under the knife for anything, there's risks of anesthesia. There's risk of bleeding, risk of infection, risk of scarring. Those are kind of the standards that I always talk to patients about. With thyroid surgery in particular, there's a couple of risks that need to be mentioned. The first one has to do with a very important nerve. So it's called the recurrent laryngeal nerve, and it's the nerve that controls the motion of your vocal cords. Obviously very important for speaking, swallowing, and breathing. Now, that nerve naturally lives behind the thyroid in the space between the trachea or the windpipe and the esophagus. And so during surgery, what we have to do is we have to identify that nerve, and we have to carefully separate it away from the thyroid and leave it unharmed. And so during surgery, we use what's called intraoperative nerve monitoring. So essentially, patients asleep, they have a special breathing tube, and that breathing tube has a monitor on it. And we have a technician in the room whose only job throughout the entire surgery is to take a look at the signal from the nerve to make sure it's happy. If at any point I'm making the nerve unhappy, they tell me right away. So you kind of have that real-time feedback, which is not something we had in training.
No.
In training, there was no monitoring.
No.
It was just hope for the best and go for it. And we had great outcomes.
Because, we did, for sure. And you'd find out after the surgery how things had gone, and then you'd hope that if there was any weakness that it would recover, and in 99.9% of the time it did. Because of the nature of the training that we had. But
And it's important also, I will mention this, is a little bit nuanced, but I will mention this because if you're taking out the entire thyroid gland, let's say you take out the first half, you've done something that made the nerve unhappy, that's your signal to stop, right? Because you don't want to go to the other half and potentially make that nerve unhappy, because if both vocal cords aren't working, then a patient's going to have difficulty breathing. It brings on a whole bunch of other issues. So it also gives us kind of a hard stop during surgery if for whatever reason the nerve is unhappy. So all that being said, the risk to the nerve in terms of permanent injury, especially in a benign thyroid nodule, less than 1%, I would say, is the risk of that happening. So very, very rare. As long as you're having your surgery done by a high volume thyroid surgeon, somebody who does this a lot.
Can't emphasize that part at the most. You really need someone who's doing this all the time. where it's to them it's just another day of putting on their shoes.
Yep.
And so it's really we see it, and there's a lot of literature out there to support it, right? Like that the more that anyone's doing of these things, the outcomes that they have overall, the number of times that they'll have these injuries or things like that out of 100 or out of 1,000 drops astronomically in that number.
Yep.
We deal with the complications of it all the time when people aren't doing it as frequently or things like that.
Yeah. And then to circle back to the other, particular risk for thyroid surgery has to do with the parathyroid glands. And, at some point in the future, we'll talk about parathyroids also because it's its own thing. But the parathyroids are small glands, are about the size of your pinky nail. Yeah, generally people have 4 of them, 2 on either side, and they live behind the thyroid gland. So they're very loosely attached to the thyroid. In most cases, they don't need to come out with a thyroid. So what we have to do is we have to separate them away from the thyroid gland, leave them alone. Now, because they're so small, their blood supply, the little artery and vein that go to them, are very fragile. So sometimes during surgery, just manipulating them, just moving them from point A to point B out of the way can make them a little upset. They may not work the way they should.
They are finicky little buggers.
They very much are.
Yeah.
So sometimes you can have a little bit of a dip in calcium level after surgery, which is usually temporary. But that's another thing that patients have to be aware of. In terms of, the recovery from surgery, generally very well tolerated. Not a lot of pain, right?
No, I truly, like, of all the things I've seen with thyroid surgery, like of other surgeries, most things in the neck, oddly enough, don't generate a whole lot of pain. But particularly thyroid surgeries, people are just fine with Tylenol and Advil, and they're good to go. And they might take it for a day, maybe 2.
And that's one of the most common things that patients are scared of, because you just think intuitively that having surgery on your neck is going to hurt like hell.
Yeah.
It really doesn't.
No.
So pain control is usually not an issue. The only restriction I have for patients generally is no strenuous exercise, no heavy lifting above 10 to 15 pounds for about a week. After that, get back to it.
Now, has the practice changed? We used to traditionally always admit these people overnight. Some people would put drains in. Some people wouldn't put drains in. There was all kinds of various discussions at conferences. It would be a hot topic that people were like, I don't put drains in. Haven't done it for the last 200. And then someone will say, I do it every single time because I had one bad bleed. And so what generally now is that? I'm sure that debate is still going on. But I mean, what generally now are you doing personally, and what do you find?
So it kind of depends. So in terms of admitting patients after surgery, if it's a hemithyroidectomy, meaning I'm only taking out one half, I will not admit those patients. I'll get them home same day. If it's a total thyroidectomy, I usually observe them overnight for 1 night in hospital for 2 reasons. One, to make sure there's no bleeding under the skin, because that can become an emergency if it happens. The second one is I want to make sure their calcium levels are stable. Because when you're taking out only one half of the thyroid gland, theoretically, you're not even going close to 2 parathyroids. So you're not going to cause any kind of calcium issues. If you're taking out both sides, that means you're going to be seeing all the parathyroids. You just increase the risk that there might be some calcium drops. So I like to keep patients in hospital, take a look at their blood work a couple times overnight, just make sure the calcium level is normal. Get them home the next day.
Awesome.
In terms of drains, it depends a little bit on the size of the thyroid. So if it's a really big goiter, we've taken some footballs out of necks before. So if it's one of those,
and just so everyone knows, goiter is just the fancy word. I don't know who came up with it. I really have no idea.
Yeah,
I should look it up one of these days. But it's the fancy word for a really big thyroid.
Yeah,
that's it.
Yeah. So if the thyroid's really big, when you remove it, it's going to create a lot of dead space. So now dead space basically is a principle that when you operate on somebody and you take something out of them, the body does not like that empty space. So it fills that empty space with fluid, with blood, et cetera, et cetera. If that sits there, that can become infected. So in cases where we're taking out a really big thyroid gland where there's going to be a lot of that space, the drain helps to kind of seal everything in. So it closes that space earlier rather than later, so you don't get that collection of fluid. So in those cases, I will put a drain. I also consider putting a drain in, Sammy, when I take out lymph nodes with the thyroid.
Makes sense.
When you take out lymph nodes, you generally will get more of that fluid collecting after surgery. So in those cases, I will put a drain.
And in those cases, you're also you have some small but still possibility of you're worried a bit more about what we call a chyle leak too in some of those cases, right?
Absolutely. Yeah.
So, and for those who don't know, chyle is another strange word that medicine came up with, but it just refers to the stuff that's in your body that's not blood, that's not serum, it's the things that your lymphatic system are bringing back towards the bloodstream.
Yeah.
So it's usually filled with a lot of fat and milky-looking appearance.
Yeah.
Depending on your diet, though, you can make it look clear if
Yes.
it's if you're not eating a whole lot of fat.
Yeah.
But anyway, I digress.
Yeah. So in those cases, because the what's called the thoracic duct, which is the kind of the channel where that chyle flows, is within the lower neck. Sometimes if you have to remove a lot of lymph nodes, you can inadvertently injure it. And so then you can get what's called a chyle leak, where that fluid can leak into the neck. And so in those cases, a drain is essential in treating that.
Yeah, and they can be pesky things to fix, but usually with the standard management that we always do, that tends to get resolved in a day or so.
Yep.
That's great. So now let's say everything's done. Surgery goes great. Patient high fives you on the way out. What do they do next? Now the tumor's gone. Do they have to worry about this thing coming back, or what kinds of things do we do for panicking or not panicking?
So the next step is to actually wait for the final pathology report. So, the fine needle aspiration is very good. It's very high accuracy, about 95%. It's not 100 though. So the final pathology is basically referring to the fact that everything we take from a patient, meaning their thyroid or any lymph nodes, it all goes to the pathologist so they can give us 100% accurate kind of description of what things look like. They can confirm or basically reject what the aspiration biopsy showed us. So if it confirms, that it's a cancer, well, then it depends a little bit on some features of the cancer. How are the cells behaving? Are they affecting blood vessels? Are they affecting, lymph nodes? Are they busting out of the thyroid gland? All of those things kind of influence what happens next, because in a lot of cases, if it's a small cancer with no aggressive features, we just watch. We just do ultrasounds. We keep an eye on things, and generally they don't come back. However, if it's a more aggressive type of thyroid cancer, if it's gone into lymph nodes, if it's attached itself to things outside of the thyroid glands like muscle, then you may need to do something called adjuvant radioactive iodine treatment, which is a treatment that's ordered by the endocrinologist, which basically works by giving a very high dose of radioactive iodine, which basically kind of mops up any thyroid cells that might be left in your body.
That's really neat about radioactive iodine treatment and how that works. I always found it very fascinating. It'd be fun to tell everybody like exactly how that kind of actively works after you've already taken out the thyroid. Explain, why would radioactive iodine make any difference here?
So the thyroid cells themselves are kind of an iodine repository. They kind of store it in our bodies. And so the principle behind the radioactive iodine is that the thyroid cells in your body that may be left over, because surgically we take out all we can see, but we can't see individual cells. So any cells that are left over that are thyroid in origin are going to take up this iodine. And because it's radioactive, that radiation itself will then kill the cells. So it's a way of kind of doing a more targeted approach rather than using actual radiation beams coming from the outside. It can actually target just the thyroid cells themselves on the principle of how they take up the iodine.
Yeah, it's really neat because you're truly just targeting the gland itself, and very little at all gets affected by it. Versus external beam radiation, you deal with that all the time, and the complications of it can cause all kinds of muscle scarring and things like that. Very necessary, but it has a broader effect on the area for sure.
Yeah.
That's great.
And there are some things that you do have to be aware of with radioactive iodine. So, the endocrinologists are really the experts in it, but there are certain things you have to do in terms of your diet, in terms of staying away from iodine-rich foods for a period of time. You have to adjust your thyroid hormone dosing for a period of time. And then once you take the medication, there's a certain window, if I'm not mistaken, about 72 hours where you have to isolate because you are technically radioactive. That's right. So you got to stay away from small children. You got to sleep in a separate room, use a different bathroom. So there are some things that go along with it, but I would agree with you, much better tolerated than traditional external beam radiation therapy.
Yeah. No, it's one of those things that it's very neat to see how the body's working and then how we do targeted things to make it work in a different way, but without hurting others. And this is one of those ones that has been around a while, even though now we're getting into much more of a targeted, personalized type of medicine, which is neat.
Yeah.
That's great. So, on the topic of diets and things like this, a lot of people often ask me, and, I try to give some responses, but I'm curious to know what you say for people come in worried about the thyroid, or they have a nodule that we're just watching or whatnot. They often ask, what can I do myself to prevent any of this? Or what can I eat, or what can I, not do or not expose myself to? Do you have anything that you tell people this or no?
So there's nothing proven to actually, be effective in either shrinking a nodule or making it go away or preventing them from occurring that you can do in terms of your diet or lifestyle. I mean, there's certain things which are correlated with a higher risk of thyroid cancers, like exposure to radiation, for example, and Chernobyl, Fukushima, there's patients who've been exposed to radiation who develop thyroid nodules and thyroid cancers. But, besides that, in terms of things you can eat or certain exercises to do or certain supplements to take, there's nothing really proven to adjust, change the thyroid nodules in any way. And that's important for patients to know because it's not something that you brought upon yourself in most cases. It's just something that happens. Again, 50% of the population will have them. Unfortunately, we don't have a good reason why.
And that's very true, yeah. We still don't know exactly why they start forming for whatever reason that is.
Yeah.
I'm sure at some point we will. But
yeah.
Man, this was awesome having you here. As always, it's a pleasure. The podcast enjoys your company. There's no question about that. I think the public really does benefit having you here. I know the team here in Arlington Heights and in the Chicagoland area is tremendously blessed to have your expertise and skill here. I know I'm tremendously blessed to have you as my partner. So, I look forward to the next time I have you back over here. And I think we're kind of teeing things up. It sounds like we've teed it up now. We've already talked about thyroids. We're going to go into parathyroids a little bit. What do you think?
Correct. I think a good deep dive on parathyroids, calcium issues. I see a lot of patients with that kind of problem. So I think next time we can tackle that.
Yeah, so we can tune in next time for that. But buddy, thanks so much for coming.
All right, my pleasure.
Yeah. All right, everybody. That wraps up today's episode of the Intent Medical Group podcast. A big thank you to Dr. Neil Mundi for joining us again and sharing such valuable insight. If you enjoyed this conversation, be sure to follow or subscribe so you never miss an episode again. And if you're new to our podcast, welcome again. We're glad to have you here. You can learn more about our providers and services at intentmedicalgroup.com, and don't forget to connect with us on social media. We'd love to hear from you. Drop us a comment or send us a message on the social media platforms. Thanks for listening. We'll see you next time.